Good afternoon to all of us joining us today on our maternity service agenda webinars. My name is Dr. Dominic Akateba. I'm a physician specialist and I work with Ghana Medical Help as the Director of Operations. This afternoon, we're having part 2 of what we started last week. We started talking about hypertensive diseases in pregnancy. Dr. Okyere did a legendary job, gave us the background of hypertensive diseases in pregnancy. If you love physiology like I do, you'd have enjoyed that presentation. And most of us who joined last week will attest to that. Because of the brilliance of that presentation, we had to divide it into 2 so that then we'll get the basic sciences, we'll get the background, we'll get the reason for people developing hypertension in pregnancy, the risk factors, and all of that. So just as much as we enjoyed last week's presentation, today we are looking at the real meat of the game, especially those of us who are in clinical practice. You want to know what to use, how to manage that hypertension in pregnancy, what to do at the level of a nurse, at the level of a physician assistant, at the level of a general practitioner, or even an obstetrician gynecologist. So today we'll learn a couple of good things from Dr. Okyere about management of hypertensive disorders in pregnancy. Like we always do, a few household keeping issues for us to take note of. Once he starts the presentation, you realize that you will be unable to unmute yourself. So we do this so that there won't be someone who inadvertently unmutes himself and then there's a lot of background noise. So we would make you unable to unmute yourself. However, the chat box is available. And so you can suggestions for the improvement of these presentations up in that box. However, at the end of the presentation, we'll have a good discussion around the topic points so that then will allow you to unmute yourself and then go ahead to ask a question, make a suggestion, or any comment that you may have. Without much ado, kindly join me in welcoming Dr. With the management of hypertensive disorders in pregnancy, Dr. Aidan Sanwe, who is an obstetrician gynecologist and the medical director at the Upper East Regional Hospital in Bolgatanga, is the supervisor for Dr. Okyere, and he would give us his expert opinions as well as contribute to answering any doubts, any questions you may have. So this is the team for this afternoon. I'm certainly sure we'll all learn a lot. So kindly stay tuned. Within the next hour, we should be out of here. Thank you so much and have a great one. Dr. Okyere, you are welcome. Kindly lead us with this presentation. Thank you.
Thank you very much, Dr. Akateba. Like you said, my name is Dr. Okyere, and this afternoon we are going to take us through the management of hypertensive disorders in pregnancy. So by way of beginning, the management varies depending on the severity of the endothelial damage that you have going on and the level of damage of multisystemic disorder that the pregnant woman presents with. So it's very necessary that we optimize our surveillance so that we'll be able to pick up any ominous changes in blood pressure, any critical laboratory findings that we pick up, and then the clinical signs and symptoms that point towards severe disease in severe hypertensive disease in pregnancy. So the basic tenets for management of any pregnancy complicated with preeclampsia is 1, either we terminate the pregnancy or deliver the baby with the least possible trauma to the mother and fetus, birth of an infant who subsequently thrives, and complete restoration of health to the mother. Okay, I'm having a challenge moving on to the next slide. Okay, so with management, we decided to pick each of the hypertensive disorders in pregnancy and go into a little bit of detail with the management as you go by. So our first on the list is chronic hypertension in pregnancy. So with chronic hypertension, the management starts off at the pre-pregnancy counseling, because you know this pregnant woman already has chronic hypertension, and you would want to see them early enough when they decide to want to get pregnant. And then if they're on any medications that will be deleterious to the baby, you stop these medications. And according to the evidence that we have, you stop these antihypertensives before she achieves pregnancy. If she's on ACE inhibitors or ARBs, these antihypertensives are very important because, for instance, if someone has the chronic hypertension in addition to diabetes, you would want to opt for your ACE or ARBs because of their renal protective effects. So if a patient comes to you who is a chronic hypertensive and wants to get pregnant and is already on these antihypertensives, it is advised that within 2 working days of noticing that the person is pregnant, the woman is pregnant, you stop these antihypertensive medications. So why do we stop them? Because ACE inhibitors and ARBs particularly block the renin-angiotensin-aldosterone, the RAS pathway. Especially for ACE, its effect is more seen in the second trimester because we all know that the fetal kidneys starts forming and they become fully functional around 16 weeks. That's the beginning of the early phase of the second trimester. So when they are taking these medications around that time, you end up having a fetal renal damage. ARBs don't just cause the fetal renal damage, but they go all the way to cause lung dysplasia, cranial hypoplasia, lung contractures, there's an increased cause-specific risk of IUFD and early neonatal deaths on patients who are taking ARBs all the way into the second trimester and even the latter trimesters. So these outcomes may be due to fetal hypoperfusion and reduced fetal renal blood flow, which eventually lead to renal fetal kidney ischemia and anuria, and eventually, since the baby's kidney function and urine production contributes to the formation of glycol, once there's anuria, it will end up causing oligohydramnios. And once there's oligohydramnios, because there's a little fluid for the baby to move freely, there's limited movement because of the extent of the oligohydramnios. And this may cause restricted fetal mobility, and eventually to lead to limb contractures, craniofacial deformity, and lung dysplasia. So when do we initiate antihypertensive treatment? So previously it was thought that you would wait till a chronic hypertensive woman comes to you and the BPs are way high, like in the severe range, 160, 110 millimeters of mercury or more, before you start antihypertensive treatments for them. But however, the current recommendation by the ACOG and then the Society for Maternal and Fetal Medicine clinical guidelines, based on the CHAP trial that was conducted in 2015 all through to 2021, recommends the following: that a strategy of targeting BP to less than 140 or 90 millimeters of mercury in patients with mild chronic hypertension in pregnancy is associated with better pregnancy outcomes than waiting till they have severe BPs before you initiate your antihypertensive treatment for them. And again, for patients who are already treated on good BP control on selected antihypertensive before the pregnancy, it is advised that they continue their antihypertensive therapy during pregnancy, except of course those pregnancies and those antihypertensive medications are contraindicated in pregnancy. So in which case you have to change them to regimen that are compatible with pregnancy to achieve treatment goal. So for them, the first line antihypertensive medications were oral orbitalol and based upon patient and prescriber preferences. So we start the antihypertensive therapy when the systolic blood pressure is at least 140 millimeters of mercury, or the diastolic pressure is at least 90 millimeters of mercury, or both. Our target BP that we are looking at is 135/85 millimeters of mercury. So according to the chapter, the drugs of choice that they used were oral labetalol. We know over there, the Caucasians, they prefer other antihypertensive as a first choice, but in blacks, we do better on the calcium channel blockers. So we would prefer to go with the extended release nifedipine for women, for our women, and then the recommended dosage is up to 120 milligrams for women without tachycardia. So aside nifedipine, which is the extended release type, you can go in for oral labetalol, which is also safe and effective. The usual dosage is from 200 to 2,400 milligrams per day for women without any contraindication to beta blocker usage, especially those with bronchial asthma, cardiac disease, reduced left ventricular function, heart block, or bradycardia. So metal dopa is also considered. You can also use metal dopa, and it can be taken BID or TID with a maximum dose of 3,000 milligrams per day. So this is the antihypertensive, that's the oral antihypertensive medication that we can use in chronic hypertensives who present to us in a maternity setting. All right, so the caveat here is that initially we are using the sublingual form of oral nifedipine, but then the immediate formulation should generally be reserved for control of severe BPs. So it is recommended that we don't use sublingual approach to control sublingual nifedipine to control BP anymore. It is only used in the acute setting when there's very high BPs. We'll go into details with that when we are discussing severe preeclampsia. All right, so the next level, aside the antihypertensive therapy, remember that we talked about this last week, where we talked about low-dose aspirin therapy for high-risk patients that come to us. So since chronic hypertension falls under high risk, we start them on low-dose aspirin regimen in addition to the antihypertensives that they are taking. And it's typically started between 11 to 16 weeks gestation, but ideally, we want to start it at 11 weeks gestation. This is according to the ECO guidelines adapted from 2019. So that is for chronic hypertension in pregnancy. So this is a flow chart looking at the management for preeclampsia. And because it's a progressive disease, that's why we picked the flow chart. So it helps us know where we are on the timeline of managing preeclampsia. So when we suspect or we recognize that a pregnant woman has preeclampsia, that is, she has a BP, it is at least 140 or 90 millimeters of mercury on 2 consecutive readings, at least 4 hours apart, plus either proteinuria of 1 plus or more, or there is a BP of 160 over 160, I beg your pardon, is over 110, not 100, over 110 millimeters of mercury or more. And it's confirmed within 15 minutes. All this after 20 weeks gestation in a previously normotensive patient. The first line, of course, is to inform a senior most person. So those of us at the peripheries, at the CHIPS compound health centers, it's advisable that we start our initial antihypertensive protocol, and depending on whether we have severe features, whether the BPs are 160 and 110 millimeters of mercury or more, then we do a loading dose of max of it. Then we document and refer to a higher center. The higher center should have a supervising specialist, OBGY specialist, who oversee the case. So when the patients come at the referral point, when we receive the patient, it is prudent that the patient is admitted for comprehensive evaluation, which includes detailed history, examination. We do our PET labs, which includes full blood count, renal function test, liver function test, lactate dehydrogenase uric acid, and then our scan studies. So when we do all these things and the results come out, if the patient is found to have preeclampsia, that's the arrow pointing towards the left of your screen to the upper part, is preeclampsia without severe features, which is the BP is at least 140 or 90 millimeters of mercury, but it's less than 160, 110, and there are no severe symptoms. Laboratory findings came out as negative in the severe category. Ultrasound findings are normal. Then the second approach, the next step, is dependent on the gestational age of the pregnancy. So if the pregnancy is at 10, that's 37 weeks or more, immediate delivery within 24 hours is advocated. The mode of delivery should be based upon obstetric assessment. But if the patient is preterm, less than 37 weeks gestation, we will manage as outpatient based upon the care plan below. So that's when we move downwards to the bottom left corner of our screen. So the components of outpatient care are weekly A&C follow-up by a doctor, assess for the development of severe symptoms, BP control with oral antihypertensive agents. The target BP, as we've mentioned, should be around 135-85 millimeters of mercury, but anywhere around 130 to 139 systolic and 80 to 89 millimeters of mercury diastolic is fine. We need a weekly PET labs, PET labs, and these two blood counts will be looking at platelets. The liver function test will be looking at our transaminases. The renal function test will be looking at our serum creatinine. And then we do a weekly obstetric scan, which involves a fetal growth. We do a biophysical profile, non-stress test, umbilical artery Doppler studies. If the patient is at 34 weeks, it's less than 34 weeks, we give corticosteroids to mature fetal lungs. And there are two approaches to go by this, either a 1-day betamethasone course or a 2 days dexamethasone course. The betamethasone dosage is 12 milligrams, 12 hourly for 1 day. And then the dexa is 6 milligrams, 12 hourly for 2 days. So the next point is to teach the mother how to monitor fetal movements and fetal K count. If there are reduced movements and or development of symptoms, prompt immediate return to the hospital is necessitated. Of course, if you are in a setting like ours here, where a number of these clients that come to us are illiterate, it will be very difficult to give them form that they should go and assess fetal movements themselves. So and then letting them go on outpatient basis and to be returning to you every now and then, the travels, the distance, the financial burden on the patients to all these things usually are the downsides of going by the component of outpatient care. But when these things stand, it goes a long way to help the patient with conservative management. So if there are severe features of preeclampsia, when they develop, it's better that you admit, it's required that you admit and then deliver immediately. But if the severe features of preeclampsia do not develop, then deliver at 37 weeks. That's for the preeclampsia without severe features. So on the extreme right, that's if you assess our initial assessment, we pick up that the patient has preeclampsia with severe features. That's any of the following: a BP of at least 160 millimeters of mercury systolic and 110 millimeters of mercury diastolic. Then the patient has persistent headache with altered mentation, loss of consciousness, persistent epigastric, and or right upper quadrant pain, visual changes, blurred vision, sparse photomata, photopsia, blindness, or there's evidence of seizures or eclampsia, or reduced urine output, or there's pulmonary edema, or SpO2 is less than 90, or you do your lab findings and you see that there's thrombocytopenia, platelet count is less than 100,000 per microliter, there's elevated liver enzymes, AST and ALT levels are twice the upper limits of normal, or there's elevated creatinine levels, which is more than 1.1 milligram per deciliter or 90 micromole per liter, or a doubling of serum creatinine, or there's evidence of intrauterine growth restriction, or there's evidence of DIC, or you find out that there's abnormal umbilical artery Doppler studies, or there's HELLP syndrome, then these patients fall under severe preeclampsia with severe features. So the management is in 3 goals: goal 1, goal 2, and goal 3, which we'll go into it very shortly. So for the goal 1 is to prevent and or control convulsions, fits, or seizures. So the first line is to give magnesium sulfate as follows: the loading dose. The loading dose is given if it has not already been given and documented at the peripheral setting before referring to the higher center. So it's given as 14 grams given as IV 4 grams of 20%, followed by IM 5 grams of 50% with 1 ml of 2% lignocaine in each buttocks. The maintenance dose is IM 5 grams of 50% with 1 ml of 2% lignocaine in alternate buttock every 4 hours for 24 hours after delivery or last fit, whichever occurs last. If the patient convulses again, we give IV 2 grams of 20% and continue with the maintenance for 24 hours after delivery or last fit, whichever occurs last. You check for magnesium sulfate toxicity and signs of kidney injury before administering the subsequent doses, because the kidneys are the only organs for excretion of magnesium sulfate. So whenever you have oliguria, which is measured as less than 100 ml of urine in 4 hours or less than 30 minutes of urine per hour, then you want to be looking out for other signs of magnesium sulfate toxicity, which include hyporeflexia, reduced deep tendon reflexes, or there's depression, respiratory rate is less than 16 cycles per minute. If this happens, what you do is you give just half of the initial dosage of the max sulfates that you want to give. And then if there's persistent toxicity, what you do is you would stop the magnesium sulfate and then you give the antidote, which is calcium gluconate or chloride. And the dosaging is 1 gram of 10% over 10 minutes. Then you give supplemental oxygen to support the patient. That's for the goal 1 of magnesium, preventing seizures with max sulfate protocol. Then the second goal is to control the high blood pressure. So the high blood pressure, you're going to use your parenteral antihypertensives. So if the BP is more than 160 over 110 millimeters of mercury, you start with IV labetalol. You give 20 milligram bolus. So you repeat as needed every 10 minutes. You can double it to 40 and then 80 milligrams, or repeat at 80 milligrams until the BP is less than 160, 110 millimeters of mercury. The maximum total dosage is 300 milligrams in 24 hours. If there's no labetalol, you can opt for IV hydralazine, which dosage is at 5 milligrams. You can repeat every 30 minutes until the BP drops out of the severe range, and the maximum total dosage is 30 milligrams in 24 hours. Or you can use the oral immediate release, the plain nifedipine, 10 milligrams. And this time around, you repeat the BP measurement at 20 minutes interval. If the BP remains high, still in the severe range, at 20 minutes, you give 10 or 20 milligrams orally, depending on the initial response. Once the BP is well controlled and is out of the severe range, you continue with your oral, other oral BP medications while you're targeting you're hitting the targets of 135 on 85 millimeters of mercury, and anywhere between 130 to 139 or systolic, or 80 to 89 millimeters of mercury diastolic is preferable. So that's the second goal. The third goal is to plan for delivery, which is in the next slide. So for our delivery plan, once you see a patient with preeclampsia with severe features, within 24 hours, you should have a delivery plan for the patient. And this will depend on the gestational age of the woman. So if the pregnancy is at 10, at least 37-week gestation, you initiate delivery within 24 hours. If the pregnancy is late preterm, that's 34 to 37 and to less than 37-week gestation, you offer expectant management in hospital if no evidence of maternal and fetal compromise are present. So for mothers at 36 to 37 weeks to less than 37-week gestation, you suggest to the mother and caretaker for the initiation of delivery. But if the pregnancy is an early preterm from pre-viable states at 28 weeks to less than 34 weeks gestation, you offer the components of expectant management to the patient. These patients have to be managed inpatiently with no baby, no home, strictly. So a daily maternal and fetal assessment for indications for immediate delivery, 4-hourly BP checks are necessary. You do your daily labs, full blood counts, as usual. You're looking at the platelets, LFT, you're looking at your transaminases, renal function test, you're looking at your serum creatinine and electrolytes. Then you administer corticosteroid for fetal lung maturation, either betamethasone or dexamethasone. Then you control the BP, oral nifedipine, metadopa, or labetalol, or a combination of these with a target BP of 135 or 85 millimeters of mercury. Then you ensure that you complete your max sulfate doses, max sulfate protocol. Then you do a daily CTG if it's available. You monitor fluid intake and output. You do a twice weekly ultrasound where you're looking at fetal growth, BP by physical profile, non-stress test, and umbilical Doppler artery studies. And you deliver immediately if indications for immediate delivery develop. Now, the third part is there are a certain group of people that would not qualify for these expectant management. So indications for immediate delivery or contraindications for expectant management, not delivery, sorry, that's a typo, irrespective of gestational age. So if there's an abnormal neurological features, as intractable headache, refractory to treatment, repeated visual scotomata, there's eclampsia or stroke. The second one is repeated episodes of severe BP that's greater than 160 or 110 millimeters of mercury, despite maintenance with 3 classes of antihypertensives, what is classically known as resistant hypertension. And then if there's pulmonary edema or there's SpO2 that is less than 90, or progressive or worsening thrombocytopenia, or there's a need for transfusion, or your lab values are deranged in the severe range, there's non-reassuring fetal states, there's abnormal fetal testing, there's oligohydramnios, there's hemodynamic instability like shock or persistent epigastric pain, right upper quadrant pain that is unresponsive to analgesics, myocardial infarction, cardiomyopathy, coagulopathy, HELLP syndrome, abruptio placentae, or preterm prom. And then the last one is maternal request for immediate delivery. If the mother insists after careful counseling that she wants to have the baby delivered, you do your part and counsel them. Because if things turns out really quickly, she can take you on and see you. All right. So all these are the goals of management, the plan for delivery, the goals of management. So what about intrapartum care? So the route of delivery is based on standard obstetric assessment. So continuous maternal fetal monitoring is necessitated by use of CTG. So you treat severe hypertension promptly with intravenous antihypertensive, as you've mentioned, and neuraxial analgesia is generally safe and effective. And we limit fluid intake to about 60 to 80 mL per hour. So we continue with the intrapartum care. So if there are no contraindications to vaginal delivery, you induce labor with Foley's catheter induction with misoprostol sequence. Then you shorten the second stage with vacuum extraction. But if it's a preterm, you do a forceps delivery to help with to hasten the second stage. If at any point there's fetal distress developing, you stop all that and then you prepare and proceed to emergency cesarean section. Then you use oxytocin for test aid management. Then for postpartum care, immediate and intermediate, it's necessary that the woman after delivery stays at the labor ward for 2 to 4 hours. Then you transfer to the lying-in ward thereafter. Then you monitor the BP 2 hourly, then 4 hourly for at least 3 days. You complete your max surface protocol. Then daily PET labs, your full blood count, you're looking at your platelets, LFT, you are looking at transaminases, renal function tests, you are looking at your serum creatinine until 2 consecutive sets of data are normal or trending to normal. Persistent severe hypertension should be treated, and then you taper doses off slowly after day 3 to 6 postpartum. Typically, after the delivery of the placenta, the BP tends to come down. So in some cases, you may not necessarily need high ceiling doses of antihypertensives to control the BP. So you taper it, you titrate it against the BP. So unless unstable, most mothers should be discharged after day 5 of delivery. Postpartum care, there's short-term and long-term follow-up. So it's recommended that the patients are reviewed at week 1, week 3, week 6, and week 12. Repeat labs at these points. Further workup is dictated by persistent abnormalities including secondary causes of hypertension or underlying renal disease with persistent proteinuria. Then it's important that the mental health group units assess for depression, anxiety, and PTSD. This is a portion that we normally don't really look at. So we also should be ready to offer information for the increased risk for cardiovascular disease, stroke, diabetes mellitus, venous thromboembolism, CKD, recurrent preeclampsia, and subsequent pregnancy. And regular, preferably yearly follow-up with BP checks and periodic fasting, lipids, and blood sugar. And we should link up with a primary care physician to continue care if there's chronic hypertension is established, those that have BPs not well controlled after 12 weeks postpartum and all that. And then prenatal counseling and assessment is in place. So that is for the management of preeclampsia. So looking at these new guidelines, comparing it with the old guidelines, with the management of preeclampsia, the old guidelines just emphasize that preeclampsia is essentially hypertension with proteinuria, but with the new guidelines, it's hypertension with or without proteinuria, but with end organ damage. So you can have hypertension with proteinuria making preeclampsia, but in some cases there will be no proteinuria at all, but just hypertension with evidence of end organ damage, and it will still qualify as preeclampsia. Previously, we were separating the hypertension group according to severity as mild, preeclampsia according to severity as mild, moderate, and severe preeclampsia. But now it's preeclampsia with or without severe features. In the old group, there wasn't any documentation for prophylaxis in ANC, but now it's recommended that aspirin prophylaxis is given to mothers who are high risk, at least one feature of high risk, or at least 2 features of moderate risk, is that aspirin prophylaxis for them. The old regimen recommended that bed rest is given for all patients, but it's not recommended in the new guidelines. The initial aggressive fluid therapy was recommended for everybody that comes with preeclampsia, but in the new guidelines, IV fluids is not routine. And not so much was mentioned about expectant management in the old regimen, but this new guidelines states they provide room for expectant management. And not so much guidance was given for mild preeclampsia. But this one, the new guideline provides home care for preeclampsia without severe features. And on and on and on and on. All right, so we look at eclampsia. So eclampsia, the definitive management for eclampsia typically ties in with the preeclampsia, but it's the supportive bits that are going to look at. So you look at 3 different scenarios. So scenario 1 is you see a patient who has already fitted, but the fits have stopped. Patient is fully conscious and stable. That's scenario 1. Scenario 2, fits have stopped, but patient is a little bit woozy, semi-conscious or unconscious. And scenario 3 is patient is still fitting. So these are the supportive care we give the patients based upon the kind of scenario we find them in. So scenario 1, if the fits have stopped, patient is fully conscious and stable, you get a venous access with a wide ball cannula. You take your samples, run your labs, and carefully preload the circulation with crystalloids, about 80 to 100 mL per hour, 20 to 28 drops per minute. You control the BP as necessary, pass catheter, and then administer your max sulfate to prevent recurrence of further seizures. And then assess patients and deliver appropriately. Scenario 2, fits have stopped, but patient is still not out of the woods yet. So you ensure that the airways are patent, protected, and then the patient is breathing well. Venous access, you run your labs, preload circulation as for scenario 1, auscultate the lungs to be sure that there is no aspiration, control the BP, monitor the BP, pass catheter, prevent recurrence of fits with max sulfate, monitor urine output, deliver as soon as the patient is stabilized. So scenario 3, patient is still fitting. Ensure that the patient does not injure herself. Do not over-restrain, example, by tying. Keep her on a mattress on the floor or even on the bare floor, and she should be clear for any objects that would cause injury to her. Then tilt the head laterally, and if on a bare floor, you should keep the head firm so that she does not hit the head severely on the hard floor. Do not force anything into the mouth while she's fitting, as this may cause injury, choking, or pushing of the tongue, but to cause airway obstruction. Once the fit stop, you continue as for scenario 2. It's previously said that you put them in a very dark room where there's poor visibility, so that it's believed that the lights trigger the seizure in them, but it's actually found out that it's not the light, it's the sound. Noise is what makes that's actually a trigger. So it's good that you put them in a well-lit room where everything is readily available and accessible, so that we can attend to them appropriately. So in conclusion, hypertension in pregnancy, in association with the development of end organ damage, has serious consequences for both the mother and the fetus. Etiology and pathophysiology are not completely understood. However, the multisystemic nature of preeclampsia is thought to be due to a combination of immune vascular response, which will eventually lead to endothelial damage, vasoconstriction, and hypoperfusion. So these events being mediated by an interplay of genetic, placenta, and circulatory factors. So diagnosis is often made at a routine visit, as symptoms are often absent, or at least initially. Treatment is aimed at reducing maternal and fetal complication while minimizing iatrogenic immaturity to the fetus. Calcium supplementation may reduce incidence of preeclampsia and eclampsia. Delivery of the placenta results in disease resolution, although careful management is required in the initial post-delivery period. Follow-up should include counseling regarding future pregnancies and monitoring of blood pressure to identify those women with chronic hypertension. The risk of recurrence is between 10 and 25%. Thank you.
Thank you very much, Dr. Okyere. This is excellent. This is great. I enjoyed the presentation. So, like I indicated, the chat box is available if you want to put in some comments in there. Otherwise, if you want to ask a question, make a suggestion, the time is now. We have about 20 minutes to the top of the hour. So what you do is to electronically raise up your hand. I would then ask you to unmute yourself, and then you can give us your suggestion or comment. So while we wait for that, I'll just read some 2 comments that are in the chat box from Dr. Salam. He says, great presentation, Doctor, very detailed and up to date. I can't agree with you, NLS, Dr. Salam. The Vida Nachi says, great presentation. I think these are the 2 in the chat boxes. Please go ahead and then electronically put up your hand, and then I will mute you. Rebecca, kindly unmute yourself and go ahead with your comment, suggestion for the improvement of this program.
Hello, sir. Hello, sir.
Rebecca, your voice is a bit distant, so we finding it difficult to hear you.
Hello, sir.
We can hear you now. Please go ahead.
Okay. Good afternoon.
Good afternoon.
Please, I have my name is Rebecca. I have a question pertaining to the maintenance dose for magnesium sulfate. According to the protocol, they said we should complete the maintenance dose 24 hours after the last fit or after delivery. So it means that even when you start with the maintenance, the person takes about 5 or 4 maintenance doses and the person fit again. You have to start the maintenance dose again. Please, I want to know the rationale behind it.
Okay. Thank you, Rebecca. So, Dr.
Yes.
Okyere.
So please, I have about two questions. And the next question,
all right.
the next one is about the magnesium sulfate. We know for the G6PD defect patients, they are not supposed to take drugs that contain sulfur. And magnesium sulfate has sulfur in it. So I want to know if they are eligible to take magnesium sulfate.
Okay, are you done now, or you have another question?
Please, I'm done. Thank you.
Okay, thank you very much. So, Dr. Okyere, kindly respond to the questions. Yeah, you can unmute yourself.
Yes, please. Yeah, so with regards to the first question. Hello?
Yes, I can hear you. Please go ahead.
Yes, with regards to the first question. So according to the protocol that we put up, it said if the patient fits again, you only give us an additional dosage of your max sulfate protocol, then you continue your max sulfate therapy. Let me go back. I'm having challenges going. Okay. Okay. Yes, so over here, so if the patient convulses again, you give your IV 2 grams of 2%, 2 grams of 20% and of the max sulfate, then you still continue with your maintenance for 24 hours after delivery or the last fit, whichever comes last.
Okay, great. I think the second question was on the max sulfate in G6PD. I don't know if it's me. I don't seem to hear Dr. Okyere. Dr. Okyere, are you there? Okay, I guess probably his network may have been off. So, Dr. Salam, please go ahead. When he connects, then he can respond.
Well, it's still regarding the lady's questions. I think the question is, why do we continue the max sulfate for another 24 hours if the patient fits?
Okay, yeah. So if you want to provide the response to it, please go ahead.
No, I didn't get the response from Dr. Okyere.
Yeah, I think his network dropped. So if you have any response, you can give to her.
Because I honestly don't. I'm quite interested in that answer and also the GCSPD.
Okay, I see Dr. Howard is on, who is with TTH. Let me ask Dr. Howard to unmute. Dr. Howard, there are a couple of questions. If you are in an environment that you can respond to. The first one is the use of max sulfate in G6PD deficient patients. Of course, with the loss of the musician, I'm sure G6PD has become very topical in Ghana. Then the second one was the administration of max sulfate as well, when the patient continues to fit despite giving it for 4 more times. Salam, did I get that right? Yeah, so, yeah, I see Dr. Somewhere as well. So any of you can respond to it. Dr. Somewhere, I've made you a co-host, so you can unmute yourself.
Yeah, hello?
Yes, sir.
Yeah, good afternoon.
Good afternoon.
Sorry, I'm on the road. I'm sure my network may not be so clear. Yes.
Yeah.
I think the first one was the rationale.
Yes.
I don't particularly have a direct answer to that. But what I would say is that most of these things are obviously guided by, and the thinking is that someone is on max sulfate for therapeutic reasons. The person has fitted. So you were doing for prophylaxis and the person has fitted. So now you move on to treatment. That's why you cannot just end at the normal dosage. So in the example she gave, you've done 5 doses. So you are probably given the last one, which is 1 more dose and end. But that obviously will expose the person within the next 24 hours of not having max sulfate to any protection. So you want to extend it for another 24 hours. And like I indicated, it's not the right answer, but it mostly will be guided by some research. And I think, particularly with max sulfate, it was a MACPI trial, which was commissioned, a multi-center trial that established that indeed the protocol should be 24 hours from the last fit or the last delivery, whichever event happens last. So that probably will be my reaction to that one. On the G6PD, it's not an absolute contraindication. We know there's sulfur in it, all right. But under those circumstances, you are encouraged to do half the dose, the recommended dose. So you won't go the full dose, but it's not an absolute contraindication. So this will be my reactions to those 2 questions.
Okay, excellent. Thank you so much. Yeah, so in the chat box, I don't see any hand up now, apart from Dr. Sanweson, which is just giving a response. In the chat box, there are a couple of messages congratulating Dr. Okyere for an excellent job that was done from Vida, from Evans, from Francisca. And then James says that it was a bit fast for him. Yeah, James, so we record this as well, and then we put it up on the Ghana Medical Help YouTube page. And so if it's fast for you, you can probably dictate the pace when you download the video from there at any moment in time. So you can, I'll put in the chat box the link to the YouTube page, which has recordings of all our maternity service agenda presentations, as well as all the other CPD programs and webinars that we've done in the past. So at your own pace, if you are slow like me, you'll be happy to probably learn from there, because that's at your pace and at your time, anytime you want to listen to it. So thank you so much for that insight. And I think he asked NS and RL. I guess that's normal saline and rigorous lactate you need. Plasma volume expanders, which may raise the blood pressure. Why are they indicated in the management of eclampsia, where high blood pressure may be a problem? Thank you. So this is the question. Any of our panelists can go ahead and answer. Dr. Sanwe, Dr. Hawa, or Dr. Okyere, or anyone. You can just unmute yourself and then go ahead with your response to that.
Please, can you take that question again? So I missed it.
Yeah. Oh, okay. Yeah. So the question was on the use of normal saline and rigorous lactate in the management of eclampsia, because the blood pressure is high, and he knows that normal saline and rigorous lactate may raise the blood pressure. Why are they indicated in the management of eclampsia, where high blood pressure may be a problem?
All right, so maybe from the part of physiology that was done last week, you would really like not to make it a bit complex, but generally the problem with in preeclampsia, elevated blood pressure is not because of volume, increased volume, but because of generalized vasoconstriction. So there are two ways of elevating your blood pressure. Either the volume, intravascular volume goes up, you have the blood pressure going up, or you have what? The diameter of the vessels reducing with the same volume intravascular. So you have the blood pressure going up. So generally that of preeclampsia is due to what? Intense systemic vasoconstriction. So though they may be hypertensive, they actually have volume depletion. Additionally, I'm sure last week he mentioned that the vessels become leaky because of the effect on the endothelial surface. So a lot of the fluid you find in there will move into third space. There'll be a lot of third space loss. So that's why you find them very edematous and all that. So intravascular, they are volume depleted. So you may be running a risk of, misinterpreting to mean that blood pressure is high, so they generally don't need fluid. But in preeclampsia, they actually need those fluid because intravascular volume is reduced markedly. And the problem is mainly because of what? The increased systemic vasoconstriction. So this will be the reason why. So they actually need a lot of prehydration before you even give your hydralazine, because you actually crash your BP if you don't do that before you give your hydralazine. Yeah.
All right, thank you very much. So Rebecca, I see your hand is up. Kindly unmute yourself. Or is it a legacy hand? Rebecca Nyami Buam.
Hello, sir.
Hi.
Hello.
We can hear you. Please go ahead.
Yeah. Please, my question is about the urine of the clients when giving the
Rebecca, I think your network is terrible. If you could kindly make use of the chat box and type out your questions, because the network keeps
sometimes you is and the client will have a clear urine maintenance dose. Is the urine color? Hello.
Yeah, kindly make use of the
Hello,
chat box
sir.
to type out your question because your network keeps breaking. All right, thank you.
Okay.
Yeah. So Dr. Swabri, please go ahead and unmute yourself.
All right, good afternoon. Please, can I be heard?
Yes, please, loud and clear.
All right. I also want to add a little to the preeclampsia with severe features and the use of crystalloids in such patients. So typically, because of the intense vasoconstriction, it results in renal hypoperfusion. And when there is renal hypoperfusion, definitely the renin-angiotensin-aldosterone system will be activated. And when it's activated, it increases the blood pressure further by causing water and sodium retention. So the blood pressure in such patients tend to get higher and higher because of the activation of RAS. So when you give them fluids, the fluids will promote renal hypoperfusion and shut down RAS. And when RAS is shut down, the BP tends to reduce and may even normalize. So that is the little that I have to add.
Excellent, Dr. Swabri. Great. So we're learning a lot, is that also? Everyone keeps contributing, especially with regards to the basic sciences. Any more question? I don't see any hand up, apart from Dr. Swabri and Samuel, which I'm sure are legacy hands. Any other question? Kindly put up your hand and then we can unmute you to talk. Akosia Boachiwa, you keep unmuting yourself. Please ask your question. Hi, Akosia. Okay, Dr. Salam, please unmute yourself and go ahead.
It was actually left the question in the chat box, but since you are not just going to put it up. It's what's the recommendation with regard to the use of diuretics, particularly furosemide, in preeclampsia or preeclampsia with severe features?
Okay, thank you. So any of the panelists can just unmute and ask. The use of the diuretics like furosemide, the loop diuretic in the management. Dr. Sanwe, Dr. Howard, Dr. Caesar, any of you, Dr. Sabri, you can go ahead.
Hello. So,
Yes, sir.
Salam, Dr. Salam. Generally, the use of diuretics is reserved for when there are complications of severe preeclampsia. So, for instance, if there's evidence that there's pulmonary edema or there's resulting acute renal shutdown, which you want to challenge, so you would want to do that. And like we indicated, because of the intense vasoconstriction, and then there's a very short window for them which they can easily get pulmonary edema. So ideally, even though we indicated that they need these fluids, when you are giving, if it's in a place where you can have access to doing the central venous access, where you monitor your pressures so that they don't overload the patient, because they have this short window where you can tip them into pulmonary edema. So if there's evidence that there's pulmonary edema, then yes, or there's a renal failure, acute renal failure, then you would want to probably challenge your kidneys with your diuretics. Other than that, typically in the management, it will not feature actively. Yeah.
Great. Thank you so much. Rebecca put her question in the chat box. It says, please, do you have to stop administering the magnesium sulfate maintenance dose when the client's urine becomes Coca-Cola colored? So, Dr. Somewhere, any response to that?
Yeah. So, Coca-Cola colored will suggest some element of hemolysis ongoing. So that will suggest probably the patient is stepping into maybe HELP syndrome of some sort, or something like that. So generally, it will require, if your lung basis and all that are okay, you would want to rather increase your hydration to see whether the urine clears. If the output is good enough, generally you would continue your maintenance dose. You wouldn't hold back just because it's Coca-Cola. So you continue your hydration if your lung bases are clear. And I'm sure with adequate hydration, you should get the urine output improving or the color improving, so that you can give your max of it. So generally, you don't hold back just because the urine is looking Coca-Cola-like, to suggest an element of hemolysis, which you have to be thinking along those lines fast managing.
Great. Thank you so much. So we are top of the hour, 4 o'clock, and so we cannot take any more questions or comments. Dr. Somewhere, your closing remarks, take-home messages, and then we can close the session.
Sorry, I had to stop and do this. So I'll hand over to Dr. What's the name?
Dr. Okyere.
Yes,
Yeah,
Dr. Okyere, can you just give a few words so that I can continue my thing? Thank you.
All right. Okay, thank you. Yeah, so thanks so much. I don't see Dr. Okyere on. I guess his network has also dropped. But Dr. Howard, Dr. Caesar, and any of the members of the team, if you have any remarks, you can just unmute yourself. Go ahead and make those remarks.
Thank you very much, Dr. Okyere, for your presentation. I'm in a place that I can't speak. There's so much noise, but I really enjoyed it. Thank you.
Excellent. Thank you very much, Dr. Howard. Any other comment from anyone? Okay, I agree with Dr. Howard. This was an excellent presentation. I did enjoy it as well. I learned a couple of things. I'm sure a lot of us would have also learned so much. Like I said, we try to make use of the 1 hour break so that then we don't go beyond what we have advertised for. And then we also try as much as possible to usually break longer presentations into two so that then people can join in as and when they are, so that we keep getting the interest and building the interest. So for next week, if you check on our social media channels, either on Facebook, Ghana Medical Help, on LinkedIn account, Ghana Medical Help, on YouTube, Ghana Medical Help, we have this presentation uploaded there on the various channels as well. So you see the advert for next week's presentation. So till next week, please take good care of yourselves. Take good care of the patients, and God bless all of us for the legendary job that we are all doing. God bless. Bye.